So hello everyone, this talk is on how to follow up a twin with ultrasound. So despite the fact that a number of studies reported an association between ultrasound markers and adverse outcomes in monochorionic twins, such as obviously twin-to-twin transfusion syndrome and selective fetal restriction. And these ultrasound markers included like discordance in ground rumplings or increased nuchal translucency or abnormal ductus. Their predictive accuracy is poor. And this recent meta-analysis concluded that early prediction of adverse outcomes in monochorionic twin pregnancies is not possible at the moment. And therefore, we only really left with ultrasound monitoring for these complications. When we wrote the ISWAC guideline, we included this flow chart, which outlines ultrasound visits, at what gestation and what should we do in each ultrasound. And certainly, we recommended that in monochorionic twins from 16 weeks, every 2 weeks, until the end of the pregnancy, we arrange an ultrasound scan. We will monitor for twin-to-twin transfusion syndrome and selective fetal restriction, as well as TAPS or twin anemia polycythemia sequence. So in every scan, we measure the deepest vertical pocket, we assess the fetal biometry, we calculate the estimated fetal weight discordance. And from 20 weeks, we do the both the umbilical artery Doppler and the middle subartery peak systolic velocity to look for the TAPS. But it's also important that we acknowledge that there is variation among the guidelines. So certainly the American College of Obstetrics and Gynecology twin guidelines do not recommend that we should routinely look at the umbilical artery Doppler in uncomplicated dichorionic twins, and even in uncomplicated monochorionic twins, where there is no size or fluid discordance, they do not necessarily recommend that we should routinely look at the Dopplers. So clearly there is a variation in the guidelines. So on a clinical, from the clinical point of view, how should we monitor, diagnosis, and manage TTTS? Well, for TTTS, as I mentioned, it's we measure the deepest vertical pocket at every scan from 16 weeks onwards. TTS has a polyhydramnios oligohydramnios sequence, and the oligohydramnios is when the deepest vertical pocket measures less than 2 centimeters, that's across the gestational age, while for the polyhydramnios, certainly the Eurofetus, or certainly the European side of the Atlantic, comment that before 20 weeks, the cutoff is 8 centimeters, and after 20 weeks would be 10 centimeters. When we published a few years ago, proposing modified diagnostic criteria for TTS, where before 18 weeks, we suggested that the deepest vertical pocket diagnosed polyhydramnios should be the cutoff of 6 centimeters instead of the 8 centimeters, because the reference range here on the right-hand side, you see that the deepest vertical pocket in monochorionic diamniotic twins, you can see that 8 centimeters is too high for early gestation. And we all have come across cases where you have the features of TTS, the abnormal Dopplers, the cardiomegaly, while actually the deepest vertical pocket never gets to 8 centimeters, and therefore before 18 weeks, 6 centimeters is more realistic option. Recently, in this study, the questioned really that we use to differentiate the 8 centimeter or having a higher cutoff of 10 centimeters after 20 weeks, and looked specifically at this group of cases that the monochorionic twin pregnancies with amniotic fluid discordance, that if you use the 8 centimeter cutoff would be TTTS, but if you use the 10 centimeter cutoff before after 20 weeks will not be diagnosed as TTTS. How big is this group? It's about 15% of all the TTTS cases that were seen or included in this study. And if you compare this group that with using the European approach will not be classified as TTTS, while using the American approach would be classified as TTTS. You see that actually this group between 8 centimeters and 10 centimeters beyond 20 weeks, about almost half of them actually Quintero stage 3, 15% Quintero stage 4, and about 80% of them have selective fetal restriction. And therefore, their argument is the fact that if we use the European approach, we will deny laser for about 15% of these TTS cases. So that's about the diagnosis and the controversies about the diagnostic criteria. What about the staging? So we know that despite sort of some of the criticisms of quaternary staging, it remains to be the commonest staging system that's currently used. Have the 5 stages, and the first one, oligohydramnios polyhydramnios sequence, you still see the bladder in the donor. Stage 2, and you don't see the bladder anymore, despite repeated scanning for a long time. And stage 3, when you have abnormal Doppler. Stage 4, when you have hydrops on one of both twins, and 5, when you have demise of one twin. So what's new? Well, the new is actually there is a proposal for a more simple staging system where you combine stage 1 and stage 2 together at one stage, and you combine stage 3 and stage 4 together at one stage. And why is that? Because if you look at the double survivor, or at least one survival, you see that actually stage 1 and stage 2, they're similar, about 70%, and at least one survival is about 90%. While stage 3 and stage 4, the survival is lower, but actually there's no difference between stage 3 and stage 4. So about 50% double survival, and there's about 80% at least one survival. And clearly you can see that obviously survival in stage 1 or 2 is better than stage 3 and 4, because stage 3 and 4, they indicate more severe form of TTTS. And therefore, really, this German study questioned the need to differentiate between stage 1 and stage 2, or between stage 3 and stage 4, because it does not really have any significant prognostic implications in terms of survival. And therefore, the new proposal, more simplified staging system, so stage 1 and 2 together, and stage 3 and 4 together. The treatment, we know that from stage 2 or higher, certainly laser is the first line, is more superior than amnio drainage, associated with higher survival and lower risk of neurological impairment. What about after the laser in terms of the follow-up of these pregnancies? We know that after the laser in the fetal therapy centers, this pregnancy will go back to the local centers and have follow-up. So what should we do in these follow-up scans? So we should measure both babies and calculate this estimated fetal weight discordance, because some of them will have selective fetal growth restriction. We should measure the deepest vertical pocket in each twin, because there is a risk of recurrence of TTTS. We should also do the Doppler assessment, so that's umbilical artery Doppler and middle cerebral artery Doppler, because historic velocity, because we're looking for both laser taps. And if any of them is abnormal, we should look at the ductus venosus Doppler. And also we should do anomaly scan, particularly looking at the heart, the brain, and the limbs, because of the association of these abnormalities in pregnancies complicated by TTTS. What about fetal growth restriction in twins? Should we use, which chart do we use, the singleton or twin charts? And it's a controversial topic, but certainly over the last few years, there's more evidence supporting the use of twin charts and assessment of fetal growth in twins. And this Canadian study, which looked at the association between fetal growth restriction and hypertensive disorder, so preeclampsia, for example. And you see here, if you look at and compare that in singletons and twins, and they did that on twins when they applied the singleton charts versus when they applied their twin charts. And if you look at the instance of fetal growth restriction in singleton pregnancies, according to whether they had preeclampsia or not, of course, if preeclampsia, they have higher risk of fetal growth restriction compared to if they don't have preeclampsia, and the risk is twice. So the relative risk is 2. What about in dichorionic twin pregnancies? If you apply the singleton charts, you don't see any difference, and you also label much more fetuses as having fetal growth restrictions, about 20 or 25%, and you see there's no difference, which is contrary to what you expect. You'd expect that if the pregnancy is complicated by preeclampsia, you also have higher risk of fetal growth restriction. What about if you apply the twin charts in dichorionic twin pregnancies? You see exactly the same strengths of association that you see in singleton. The risk is twice. If you have preeclampsia, you have twice the risk of fetal growth restriction. And therefore, supporting the use of twin references to diagnose fetal growth restriction in twin pregnancies. This is our most recent data, and we looked at a number of adverse outcomes, and I'm showing you here the data for perinatal deaths, preterm births less than 34 weeks, and admission to the neonatal unit. And this study, we ask specific, or the most important really question is that, is it wrong to use a twin charts? Do we miss pregnancies that will have adverse outcomes? And in this plots or these bars, you see the red is small babies, whether by twin chars or singleton chars. And of course, they have higher risk of adverse outcomes, perinatal death, preterm birth, and neonatal admission. What about this group, the one in blue? So that's small, using the singleton chars, but not the twin chars. And you see that there's no difference between this group and the appropriate for gestational age fetuses. So neither in the perinatal death, neither in the preterm birth, neither in neonatal admission. So you don't miss adverse outcomes if you use the twin chars when you assess with the gross twins. So what do? You label far more babies as fetal growth restriction if you use the singleton chars. In this study, about a third of twins were classified as, or would have been small if you use the singleton chars. And certainly we concluded that singleton chars misclassify a large number of twins as at risk of fetal growth restriction. What about the diagnostic criteria of selective fetal growth restriction in twins? When we wrote the ISWAT guidelines, in diachronic twins, we said we'll apply the same criteria as in singleton, so one fetus with estimated fetal weight less than 10 centile, while in monochorionic twin pregnancies, in addition to one fetus with estimated fetal weight less than 10 centile, we also include the estimated fetal weight discordance of 25% or more. After we published the guidelines, a number of clinicians wrote papers, particularly people from the States, questioning this definition because they use different diagnostic criteria. And it's true that the different studies had different diagnostic criteria, which caused confusion. And therefore, we reached this diagnostic criteria based on consensus using Delphi. We published that about 3 years ago, where if one fetus have estimated fetal weight less than 30 centile, that's enough to diagnose selective fetal restriction in twins, whether diachronic or monochorionic twins. What about if you want to use a conventional cutoff of less than 10 centile? In this case, you need, in addition to that, you need a discordance of 25% or more, or umbilical artery, abnormal umbilical artery Doppler, in order to diagnose selective fetal growth restriction in twins. I'm going to spend the next few minutes concentrating on TAPS, twin anemia polycythemia sequence, because it's probably the most controversial subject at the moment. So TAPS was described about 10 years ago, initially postnatally, with the large hemoglobin difference between the twins. And that was translated into antenatal diagnostic criteria, where the donor or the anemic twin have middle cerebral peak systolic velocity above 1.5 mom, and the recipient or the polycythemic twin have peak systolic velocity less than 1 mom. And you can see here on the chart, there's a large discordance. So that was the original or the diagnostic criteria that was proposed about 10 years ago. 2 years ago, we looked at the accuracy of this diagnostic criteria to see, are they actually detecting all cases of TAPS. And if you use a traditional diagnostic criteria, the sensitivity is only about 50% for 100% specificity. So if you find this, yes, they have TAPS postnatally, but you only detect about half of the cases. The Dutch team, when they looked at the delta or proposed to suggest or suggested, use the difference in the peak systolic velocity rather than cutoffs. And if for a cutoff of 0.5 mom, you can increase the sensitivity from 50% to about 80%, and you maintain 100% specificity. And then around the same time, the German team led by Kurt Hecker suggested even a lower cutoff of the peak systolic velocity delta, or the difference is 0.37. And by doing this, you increase the sensitivity even further, to about 90%, and you reduce the specificity to about 95%. And therefore, there is confusion. Is that which diagnostic criteria should we use? And we tried to get this consensus, again, using the Delphi, it's published last year, where actually the experts voted for if you have the donor of peak systolic velocity of 1.5. So there is an agreement to that. But the recipient of the polycythemic will use a low cutoff, so 0.8 mom instead of the 1 mom. And also they wanted to include the discordance in the peak systolic velocity, or the delta, but a much higher cutoff of 1 mom instead of 0.5 or the 0.37 mom that was proposed. And I think the reason they did that is because TAPS is one of these things that are still controversial, because there's question marks about the natural history. Not all cases will progress. and also about the management, what is the best intervention in these pregnancies. And therefore, they want probably to identify the cases that really are the highest risk group, the one that really need monitoring and intervention. How common is TAPS? Well, it depends which diagnostic criteria you use. The traditional one was about 8% of all monoclonic twin pregnancies. The Delphi, the newest one that we proposed, 6%. While actually, if you just use the delta or the discordance, you would label many more pregnancies as complicated by TAPS. If you look, for example, the German criteria 0.37, that's about 19%. So you label 1 in 5 of the monoclonic twin pregnancies as complicated by TAPS. When does TAPS occur? Will be this data from the TAPS and the International TAPS Registry, which had nearly 400 cases of TAPS, and we published 3 papers in the last couple of years. And if you look at the spontaneous TAPS, it can occur from any time from 17 weeks up to 35 weeks, and therefore we need to be monitoring for TAPS all the way through the pregnancy. What about the post-laser TAPS? 3/4 of the cases occur within 4 weeks after the laser surgery, but some of the cases can occur up to 17 weeks after the laser surgery. As I mentioned, there is a question mark about the natural history, and that's maybe why some guidelines do not routinely recommend that we should monitor for TAPS. And this is our data that we published last year, where you see about 1/4 would need intervention when they were referred to the spontaneous or post-laser. But very importantly, that not all these cases actually progress. 40% actually regressed. So the Dopplers went back to normal or did not meet the diagnostic criteria anymore. And about 10%, the green, were actually stable, did not progress. Only about 20 or 25% of these cases progressed. And therefore, what about the monitoring? I showed you what we recommended in the ACE-WOC guidelines. What about other guidelines? For example, NICE, which is a guideline in UK, they updated the guideline, published September 2019, and I was on the committee, and we had a long discussion about whether we should recommend that we routinely monitor the mid-cerebral big systolic velocity in all monoclonic twin pregnancies. And because of the lack of evidence, because of the question mark about the best management or even the natural history, that was what we agreed to include in the guideline. So we should look for mid-cerebral big systolic velocity in all cases that TTGS treated by laser, and in all uncomplicated monoclonic twin pregnancy or any deviation from the normal. So if it's selective fetal restriction, if you have abnormal pericardial Doppler, unexplained polyhydramnios, hydrops, or cardiomegaly, in all of these conditions, the recommendation was to perform weekly middle-cerebral systolic velocity from as early as 16 weeks, and of course to seek advice from fetal medicine specialist. Important is just to highlight that other ultrasound features that you can see in cases of TAPS, because sometimes that will be the initial referral. The placental dichotomy, so thick white placenta, that's the donor or the anemic side, and thin dark placenta on the polycystic side, and the sky liver, that's in the recipient, when you can see sort of the bright dots here, which is the portal, the walls of the portal venules, and the liver parenchyma, which is quite dark or reduced echogenicity because of congestion. The final point in my talk will be, does it actually matter? So does ultrasound monitoring improve the outcomes of these pregnancies? And this is data from St. George's where I work. This is a stillbirth in twin pregnancies. This is when we implemented the NICE guideline and also obviously followed by the ACE-WOC guideline. And we noted a reduction, significant reduction in stillbirths. And in fact, you see that the stillbirths reduced from about 14 per thousand to about 4 per thousand. So significant reduction. Is it in diachronic or monoclonic? We saw the significant reduction, mainly in the monoclonic twin pregnancy, with about 70% reduction in stillbirths in monoclonic twin pregnancies. I'm going to stop here and thank you very much for your attention, and I'm happy to take any questions.